Hello, everybody, and good morning. And we have a distinguished guest. They are a leadership in a private hospital in the country. So we're gonna give them some quick questions and tips. Let's start with Master David Jelley. He's a CEO in Mediclinic. Master David, as you know, the Mediclinic operates in different countries. I know that in Africa, in Europe, in Asia. So my question to you is, how do you ensure cancer care receive the long-term investment and strategic priority it requires alongside competing service line? Yeah, go ahead.
Hello. Good morning, everybody. Yeah, thank you. Good question. So I guess it all for us at Mediclinic, and just as by way as a quick introduction, Mediclinic Middle East is part of Mediclinic International. So globally, we have 54 hospitals in South Africa, 2 in Namibia, 19 in Switzerland, and 34 in the UK. Here in the Middle East, we've got 6 hospitals, and we're supported by a network of about 30 clinics. And when it comes to our commitment to the community, it's data driven. Okay, so we want to see what the data says, and if the data says that there's a need in the community, then we have to respond accordingly. We've got a duty to the community to provide that service, and so we see it in the literature as well. There's a growing trend of cancer becoming more prevalent in younger people. And in the UAE, we're seeing an aging population. It will start to become an aging population. I see. When I look out now, all I see is young people. But when we know with the new visas coming in, the UAE is becoming more accessible for people to retire, and that's exciting. And we need to react to that. I think from a service provision point of view, I think with the support of the regulators, it is a financially viable service. So we can make that. So that's one important step that we can, despite the costly biomedical, which we just talked about, pharmacy consumables, manpower, the good folk in the audience are expensive, and rightly so. But the regulators support us with tariffs that make it a financially viable service. So we're able to push on. And I think, and again, I'm just talking on behalf of Mediclinic, we're also very blessed with leadership. So from a director level, in terms of clinical director levels, both in Abu Dhabi and Dubai, I'm sure most of you know Dr. Diab in Abu Dhabi and Dr. Shahina Dawood in Dubai. These guys are very passionate. They know what they're doing. And when it comes to providing a macro view or a Dubai-wide or a pan-Dubai or a Abu Dhabi, including Al Ain-wide plan, we're able to do so.
Thank you. The following question for Dr. Ali from GICC. He's the CEO in Gulf International Cancer Center. My question is to you, as a private, usually you are adopting advanced technology, but the scale of the payment will remain is limited. So how you decide to balance between the innovation that improves the outcome, okay, with the enhancement of positioning of the payment? The question again is how you decide for the innovation adopting in your center versus the financing, the reimbursement and the payment from the government or from the insurance.
When we get the patient, we decide what to treat. That's our job. Then you have to cost the cost of how to do it. We involve the physicists, the technologists, and the physicians in all this one process, and they all work as a team. So that's very important, and they have to know each other, and they have to talk with the patient about what's the plan and give him the choices of what to do.
Right. So Dr. Mohammed Nasim from Pakistan Medical Center is a charitable and philanthropic centers. So my question to you, how do you see the BMCs cancer center primarily as a provider of access and as a model of delivering for cost effectiveness of high quality cancer care, how the other can copy you or repeat your experience as a charitable center?
Thank you very much. Firstly, Pakistan Medical Center is the only not-for-profit medical center. So that's, we are the only place where people who do not have insurance or money can actually see a doctor. And it's across all communities. So yes, our initial focus was always on the metabolic diseases, which are more prevalent, but being a center where everybody who doesn't have resources comes to, so we've seen a lot of cancer patients coming to us. Our initial focus was prevention because we have an academia arm and a public health arm, and we are trying to go to communities and teach them about cancer and also the screening. So that was the two focus areas for us, because we did not go into cancer management, but screening for the three common cancers was the main thing. One of them was the mammograms for breast cancers, the cervical cancer screening, as well as the third arm was FIT for colorectal cancer. So that was our focus. But with our expansion, yes, we plan to get more involved into cancer care with collaboration with the established centers.
All right, thank you. For Mr. David, as a cancer becomes increasingly multidisciplinary and data-driven, do you envision centralized cancer hubs within the Mediclinic or distributed model with the strong digital and governance integration? What is the tipping point of this?
Good question. I think the short answer is urban sprawl. So right now, as we sit right now, we have a bit of a hybrid model. So we have the Comprehensive Cancer Centre, which is centralised at Mediclinic City Hospital, where we have our radiation services. But we do screening, and I'm just talking, we're in Dubai, so I'll focus on Dubai for now. But then we do screening, we do surgeries, we do chemotherapies in all of our units, chemotherapy at Mediclinic Parkview Hospital. And during we have an expansion coming up, a 350 million dirham expansion at Mediclinic Parkview Hospital, which is of course down the south of Dubai, where we will build bunkers for the future so that we can add radiation services into a little bit more accessible in the south versus the north in Dubai. But it's, so what is the tipping point? Again, it goes back to data and listening to our patients, because we know sick patients, it's difficult for them to travel. And Dubai's doing great, going to great lengths to do everything they can to cut traffic. I just read yesterday, the Boring Company are coming in to put Teslas to cut traffic through underground tunnels. This is great news, but still, people in the south of Dubai will eventually be reluctant to put up with the traffic to go down the other end of town. So we need to do the right thing and provide the service, the exact same quality of service in the south.
Thank you. Dr. Ali, do you see the GICC can integrate more deeply with the public and the charitable system? And how can be the reimbursement?
Again, the question again.
The question again, GICC, how can be involved or integrated deeply with the public and the charity system of the country?
Over there, we have all kinds of patients. We have Emiratis that can afford, and we have expats that have insurance, and we have the cash payer. On the cash payer, we have big discount or refer them to places that have charity. And this is all the time we do.
So the discount, good discount, 50%, you mean?
So you finish, I would like to ask questions.
Sure.
Can I ask now when we're done?
Sure. So my last question to Dr. Muhammad Nasim, what structural changes, financing and partnership or policies are essential for charitable centers to remain sustainable?
Can you repeat?
The question it is, what structural changes, financing and partnership or policies that can you adapt to make your center sustainable to provide a good service?
Oh, thank you. Actually, all three of them. So far, the policies do not show a great collaboration between centers because cancer is a problem and it's becoming even more serious in this part of the world. So collaboration between the centers is very important. The policy, of course, will direct that collaboration because yes, there is a very good policy for cancer, the BASMA program in Dubai, but we still need a lot more to be done. The first two arms, again, the prevention and the screening has to be widespread. It cannot be left on insurances or affordability. We have to tackle the cancers at the earliest stage. So that is where more funding, more robust policies, and more collaboration that will help. So our centers can be at the forefront because we get a lot of patients from community, those who can't afford, and some numbers who are with insurance, and we can offer a large-scale screening for cancer patients. That's what is our focus, and hopefully with our expansion, we are going to take it to a greater number.
All right. Do you have a waiting list in your center? Waiting list, waiting.
We are in Dubai,
Okay.
Oud Mehta, so at Pakistan Associations Dubai. So this is the only place we open 7 days a week from 8 till 9:30, and we get a lot of patients from community.
All right. Thank you. Dr. Ali, what's your questions? What's your question?
We had all the executives here of industry, and with all due respect, I had questions and I didn't have a chance to. Our major thing, number one, there is no increase in the number of patients. We used to be the first private oncology center to provide radiation therapy, other than TOAM, which is an excellent center. Now there's 12 centers. All the patients are divided among all those patients. So everybody is treating less. On the industry part, the service contract is increasing year by year. It creates a big financial crunch on the private sector. So this is an important question. Second one, the proton is excellent, but limited use. And you have to guarantee insurance payment to those. We have a license to do it. We didn't do it because there's no guarantee to payments. Service contracts for the upright, it's a good idea. But again, not all the patients need upright. They all treat it flat. And you know, prostate, for example, chest, I understand. But the prostate with all small bowels,
Right.
it has a limited use also. And I talked about variant, because we have variant, we have Electa, but the service contracts are very high. These are things that the industry have to address from the consumer part.
All right. Thank you. In 1 minute, just there's a question from myself. So to Mr. David, in UAE, what real challenge Mediclinic facing?
I think it's not necessarily a challenge, it's an opportunity, and that's the migration of care.
Right.
So we are starting to see, from a screening point of view, more of it moving into homes. There's a lot of screening happening now in homes. And then it's about keeping up with the technology and the literature to say what's coming next. So right now we have chemotherapy suites in Mediclinic Airport Road, Mediclinic Parkview Hospital, Mediclinic City Hospital. But when is it going to be in our homes? So for us, I think a big challenge for us is it's a bit. I must say, I sympathise with your question earlier because it's a much tougher market in Abu Dhabi based on the tariff. Okay, because we both got the same costs, but we have very different tariffs in Dubai versus Abu Dhabi. So that is a challenge. And I think that the challenge that we speak about here is going to push us, incentivize us more to do more healthcare at home.
Dr. Ali, what the real challenge facing GICC? what the kind of real challenge
Hmm.
facing GICC in UAE?
Again,
Challenges, what challenges you are facing as a private center?
the challenges, the challenges that we have is that there is too many centers all of a sudden showed up in the last 2 years. So that cut down on the amount of PET-CTs and amount of radiation. It's a big challenge. Number two, the insurance companies. In spite of all that, insurance companies, they give you with the right hand and they want to take it from the left hand. They give discount 7.5% after they give it to you. What for? Okay, so these are financial problems that have to be addressed in order for the private sector to continue. Otherwise, those private sector cannot survive and they have to be all on the government. So we have to deal with that. This is a good forum to address these issues. We are always positive, which is great. And we should look for solutions to address these problems.
That's why AMSTRO come to the map for these issues, especially. Dr. Muhammad Nasim, I believe in Pakistan, the challenge is a little bit different than us.
Yeah, we are definitely different because we are the only place where, again, I have to tell again that anybody who doesn't have money, because I think the policies and the private centers think that only rich people are going to get cancer, or the patients who already have insurance are going to get cancer. What is happening to those patients who do not have insurance and who cannot afford? I think that's the question I will leave with all the oncologists and all the heads of the services. Is there a CSR somewhere to help those patients? We can go to a limit. Yes, we can make the screening cheaper for those patients, but that burden that will add, who's going to manage those patients? We are a center which works with volunteer doctors. So we are looking towards the oncologists to spare some time as volunteers for these patients as well, because we haven't received a single oncologist willing to work as a volunteer with us. So that there is a large community in UAE who needs support. So Pakistan Medical Center has taken a step, but how many other centers will collaborate, that we'll have to see.
Thank you. And to summarize this event, I believe the challenges in the UAE, number one, we have many centers. Number two, we have less patients. Number three, the technology extremely expensive. So we must all together to sit around a table with the insurance to solve this problem. Thank you, ladies and gentlemen.
Thank you, everyone. Thank you, panel and Dr.